Right, so thank you so much everyone for coming along. Welcome to this Ovarian Cancer Action webinar. The topic tonight is preventing cancer in Jewish communities. My name is Jo and I work for Ovarian Cancer Action. My role is Cancer Prevention Officer, which basically means my job is all around raising awareness of genetic testing and how we can use genetic testing and that information to help prevent cancer in the future. And I actually carry a BRCA1 mutation myself as well. This webinar is one of a series of workshops and webinars that we're running as part of our Hereditary Cancer Awareness Week, which we've launched this year. And we've got lots of sessions going on into the topic of hereditary cancer this week all the way through to Monday. So please do take a look if there's anything that you're interested in. We've got recordings of other webinars as well on our website that you can look into and watch as well. We've also recently set up a monthly newsletter specifically for people with a high genetic risk. And that's got all sorts of things, updates on research, guidelines, events that we've got going on and so on. So please do sign up if that's something that you'd be interested in to keep up to date. Just a little bit of kind of housekeeping info first on how the session will work. So in today's webinar, you should be able to see myself and our panel of lovely guest experts. You'll also see a little icon with my colleague George, so you'll see the name OVCA there on screen. If you've got any kind of tech issues or you're having trouble hearing us or anything like that, you can get in touch with George. We'll be recording this session tonight so that we can share it with you and anyone else who might find it useful in the future. So please don't feel like you need to take copious notes or anything like that, because you will be able to watch it back once we post it to our website. You'll see along the bottom of your screen there should be some buttons. Please feel free to ask questions as we go along using the Q&A button. I'll keep those questions anonymous. I won't read out any names purely because we're recording tonight, as I said. And we'll kind of get to those questions towards the end of the session, but feel free to kind of type any in as we go along that you think of. There's also a chat button there. As I say, that's one of the ways that you can contact George if you have any IT issues, or otherwise you can also use the phone number that was in your email invitation that you got to give her a call if you have any problems. We will try and get through as many questions as we can tonight, but if you have a burning question that we miss, you can always get in touch with me after this, and that's brca@ovarian.org.uk, and we'll do our best to get it answered for you. Bit of a caveat before we start, we should say that, please always consult directly with your medical team and a genetic counsellor about your own personal situation if you do decide to follow up and look into genetic testing or anything like that. So moving on to the topic of tonight. So the topic is BRCA, and we've set this session up because we know that awareness of faulty BRCA genes and the high risks of cancer that come with them is really low. We actually commissioned a survey earlier this month, and that found that 75% of people in the UK have never even heard of BRCA. So in the general population, around 1 in 400 people carry a faulty BRCA gene. But for those with Ashkenazi Jewish heritage, that number is 10 times as high. It's 1 in 40. And research actually estimates that around 89% of those in the Jewish population who carry a faulty BRCA gene are unaware of that risk. So we really need to change this. And that's, why we're here tonight. And we want to give people the tools so that they can take action if they want to reduce their risk of cancer. So we're really lucky to be joined tonight by an absolutely brilliant panel for today's discussion. So first off, we've got Rabbi Oliver Joseph, a Masorti rabbi and BRCA carrier himself. We've got Cheryl Berlin, who's lead cancer genetic counsellor at Northwest Thames Regional Genetic Service. And we have two lovely, lovely people joining us, Rachel and Talia. We're both here to tell their personal experiences of hereditary cancer and genetic testing. And I want to, before we do anything else, I want to thank you guys all so much for giving us your time tonight to help raise awareness of this topic and tell us your experiences. So to start off with, I'm going to hand over to Cheryl, who will talk through the basics of what BRCA is and what genetic testing is, so we can all be on the same page. So Cheryl, if I can hand over to you and you can share your screen.
Yeah, okay, just give me 1 minute.
Yeah, that's fine.
Okay.
Brilliant, we can see that, perfect.
Brilliant. So thank you very much for giving me this opportunity to talk to you all this evening. Obviously, BRCA in the Jewish community is something that is not only for as a professional, but also from a personal perspective, something I'm very keen on. to be sharing some information with you. So I'm going to try and run through some information really quickly. So I hope it is at the right level. So apologies if it isn't, but I only have 10 minutes, so I'll go as quickly as I can. So just a really quick science lesson, because I don't know how much people know, but obviously our bodies are made up of cells, and each cell has what we call our chromosomes, and chromosomes carry your genes, which is your genetic information. It's your instruction manual that tells you how you're going to grow and develop. And you have 2 copies of every single gene, and you get one from your mum and you get one from your dad. And when we think about cancer, cancer occurs due to an accumulation of errors in the genes. So these mistakes or alterations are called mutations, and different things could cause mutations. It can be chance due to aging, environmental factors, lifestyle, but of course also inherited factors. But it is really, really key to understand that cancer may be genetic, but it's not always hereditary. It's not always inherited. So it's only a small part of cancer cases that are due to underlying inherited causes. And that is also important. While it is important to know which cases are in the family, it is also important to understand that the vast majority are not due to inherited changes. So just a bit of a history. BRCA1 and BRCA2 have been around since the 90s, and BRCA1 and BRCA2 are what we call tumor suppressor genes. So exactly as the name implies, they suppress cells from forming tumors, and essentially they work to protect us. So BRCA1 and BRCA2 are important genes involved in protecting us from developing certain types of cancers. And as I said in the beginning, we all have 2 copies of the gene. So when someone says I have BRCA1 or I have BRCA2, what they really mean is I have a variant, mutation, mistake, error, fault, change, whatever word you want to use. But essentially there's been a change or disruption in one of the BRCA1 or BRCA2 genes that disrupts the normal function, and therefore that person loses some of their protection and becomes more susceptible or predisposed to particular types of cancers. But nonetheless, we all talk of it as having a BRCA, of being BRCA1 or BRCA2 carriers. So just already got that. So just in terms of thinking about it in terms of the Jewish population. So as you've already heard, BRCA1 and BRCA2 are and about 1 in 400 people in the general population carry a mutation in BRCA1 and 2. But in the Ashkenazi Jewish population, that goes down to 1 in 40. And it's around 1 in 100 for Sephardi Jews. Now, what's also important to say is it's not just any mutations or changes within their genes. There are 3 common changes that occur in the Ashkenazi Jewish population, and they account for around 96 or 97% of all BRCA mutations within this population group. So just a bit of information for you, a bit of background. So why is it important? So BRCA1 and BRCA2 is associated predominantly with breast and ovarian cancer in women. So the breast cancer risk in the general population for a BRCA carrier is around 70%. The chance of getting contralateral, so meaning getting more than one diagnosis of breast cancer, is around 50%. And every paper you read is going to be slightly different. So these are just ballpark figures, so just to keep that in mind. And the risk of ovarian cancer is around 17 to 45%. But we also can't forget our men in BRCA, our male BRCA carriers. So men, there's less known about the implications for BRCA1 carriers for men. There may be an increased risk of prostate cancer. There may be an increased risk of male breast cancer. But for BRCA2 carriers, there is definitely an increased risk of prostate cancer as well as male breast cancer. And BRCA2 carriers also have a small increased risk of pancreatic cancer and melanoma. The next thing to think about, and I'll come back to a little bit about what we can do about those risks, is thinking about how it's inherited. So if somebody has a BRCA1 or BRCA2 gene alteration, the chances of them passing that alteration onto their children or their siblings having that is 1 in 2, is 50%. So it's what we call autosomal dominant. So if a parent is a carrier, so if you look at the character that's in black, and that is a parent who's a carrier, then there's a 50-50 chance that each of their children may have also inherited that same genetic alteration. Equally, if you test somebody who's of a younger generation, there's a 50% chance that either of their parents may be a carrier, and it can be passed down through the male and female lines. So just briefly, just to say that in terms of there are other ovarian cancer genes and new testing protocols. And so sometimes when somebody goes ahead for genetic testing, they may be tested for BRCA1 and 2, but they may be tested for other genes as well. So other genes, just briefly, and there is no link necessarily with the Jewish community, but they may be simply because we don't know yet, or there genuinely isn't a link. And some of the other genes have a moderate risk of ovarian cancer, or with Lynch syndrome, a higher risk. So it is important to know that if you do go ahead for genetic testing, you will always be asked about your family history, or you should always be asked about your family history, so that consideration for some of these other genes can be made as well. And I know a lot of people want to know, will I be offered a test? Can I get testing? And there has been changes very recently about who will be offered genetic testing. So at the moment, any woman who had specific types of ovarian cancer should be offered genetic testing for BRCA1 and 2. And any woman who's Ashkenazi Jewish who's had breast cancer will be offered genetic testing. And if somebody's unaffected themselves but has a family history, then that would need to be explored to see whether or not they would fulfill the criteria. Now, why it's so important for us to be tested is so that although it's only a minority of cases that we see an inherited form of this, the management for these families changes significantly. So if somebody is a BRCA carrier, they would be offered additional breast screening from the age of 30, some in rare cases a bit younger, but generally from the age of 30 to 50, they get breast MRI, from 40 to 70 mammograms. And they could also consider the option of risk-reducing mastectomy, so the option of removing healthy breast tissue. Now, those are obviously quite significant surgeries, but would also significantly reduce risk. Women who want to reduce their risk of ovarian cancer is a little bit more tricky in the sense that there is no proven screening for ovarian cancer. So there's no screening that's proven to save lives. So on the NHS, there is no screening that would be offered. But what we would offer is surgical intervention again, so risk-reducing surgery to remove the ovaries and the fallopian tubes would, again, greatly reduce the risk of ovarian cancer. So I hope that's just given you a really quick fly through about BRCA and genetics. And I know a lot of you want to know, what do I do if I'm concerned? So for the NHS, you can ask your GP or your doctor to make a referral to your local genetic service. Every referral is considered. Sometimes if we can tell from the referral, we may send out a letter saying we're not accepting the referral. Might simply be because it doesn't meet criteria. But if there is a family history, we would always give advice. If they do meet criteria, we'll often send a family history questionnaire and go through all of that. And then if they fulfill criteria, we will then offer appointments. If people are considering going privately, please check the companies provide genetic counselling or an appointment with a consultant so that you understand the implications of the testing, because I've just given you a quick fly through, and that the laboratories they use are accredited. And be very wary of direct-to-consumer testing. So those test kits that they send you out in the post and they send you a report. Be very wary of them because they often don't give sufficient information along with them. So back to you.
I think that was a really, really, efficient, really helpful summary straight off. So thank you so much for doing that, Cheryl. And I hope that's given everyone a really useful background. We're going to move on to hearing some stories of our panellists who've been through genetic testing and can tell us their stories. So first off, Rabbi Oliver, I wonder if you could talk us through your story for us.
Hiya, can you hear me okay?
Yeah.
Okay, great. Yeah, I don't find it super easy telling my story, and I also notice two things that I glaze over a little bit when I hear some of the science. Sorry, Cheryl. And also that I haven't, there are some family members who are listening in or listening afterwards. I don't talk about kind of my story in full very often, and if that's just like a taste of what it is to try and talk about BRCA, I can't imagine how that is for kind of the population that we are speaking to then trying to speak to family and make decisions about BRCA. So I guess to begin with, I totally acknowledge it's just a difficult topic to talk about. For me, I guess in our family, we've spoken about cancer journey. I had cancer when I was 17, and I had a good cancer, which has nothing to do with BRCA, or at least as far as we know, which was Hodgkin's disease. And through a process of chemotherapy and radiotherapy and surgery, I recovered very well from that. I guess that was my kind of journey from adolescence to adulthood, was kind of by way of cancer at the age of 17. Not very long after that, kind of as I was recovering from the effects of chemotherapy and radiotherapy, my mum got sick with cancer, and she also kind of had her own cancer journey of a couple of years, through which she had kind of regular bouts of treatment and ultimately became very sick both from the treatment and from cancer. This is 20 years ago, so my mum would have passed away in 2002. And back then, at least as far as I knew, there was no mention of BRCA. There was no discussion of BRCA gene. I guess at the end of my story, I'll reflect back on that, because the science is constantly changing, and just that 20-year gap is so stark in terms of what we knew about BRCA then and what we know about BRCA today. Mum passed away, very tragically when we were still quite young. I was 19. Her cancer was an ovarian cancer that started in her ovaries. We knew at a young age that her mum, who she spoke of often, had also passed away from cancer, and I think even her mum's mum also from cancer. So I guess in some guise or another, we understood that there was a genetic link, but in a kind of very, now in a way that looks quite archaic. It was just what we grew up with, that mum died at a young age, my grandma, and so on. Then fast forward, I'm terrible with dates, so my family will have to forgive me in terms of dates, but fast forward then 7 years ago, so I guess somewhere in the region of 10 years after mum passed away, and my little sister Betsy found a lump in her breast, aged, I guess, 28 then, so at a very, very young age. She was living in New Zealand at that time, and she described her own cancering journey and went through her own journey, which was trying to be in relationship very much about her own choices in relation to cancer and her own journey. She was very connected to her yoga practice at the time, and lived in New Zealand for the beginning stages of her, as she described, cancer journey. My twin sister Kate also went out that time to journey with her, and to go to appointments and so on. Betsy ended up having a double mastectomy, having both breasts removed, and it was during that process that she would have also been tested for BRCA, because we're talking now, 15 years after mum died. Already there had been a significant shift in the science. And part of that understanding in relation to the BRCA, and Cheryl will know much more about this than I do, was that the BRCA gene, as Cheryl likely correctly said, it's a BRCA mutation rather than a BRCA gene. I'm learning today as well. But because of the BRCA mutation, that also affects outcomes in terms of how treatment was received for Betsy. She had a very aggressive cancer, and after I think less than 2 years of treatment, she also passed away from that cancer, and she actually had cancer which was metastasized to her head. So a brain tumor is actually a very tough way to pass away as a cancer patient. I'm already cruising towards the end of my time, but then the next part of the journey is that the two other blood children of my mother, I have two half-sisters as well, me and my twin sister, both then went to get tested. I think Kate first, and my twin sister then proceeded to have a double mastectomy and reconstructive surgery. that's the first stage of her elective surgery, preventative surgery, in relation to her desire and wish not to have breast cancer as well, or not to eliminate herself from that bracket of having such high risk of cancer. And the breast cancer is certainly the highest risk for her. I would just say, and I think Kate will be listening perhaps to this, I would just say that whilst everybody should be tested, it's not always obvious for women, and I'm not talking as a woman, and hopefully Rachel and Talia will speak to their personal experience. It's not always obvious that all of the side effects related to all of the elective surgeries are available make the elective surgeries worth it. So it has to be a decision which is personal to each of the women, and Kate certainly went through a tough time in relation to her surgeries, and even today recovery from those surgeries. So I would say that, having gone on that journey with her, even though it's her own journey. Also, the 50% chance doesn't work if you're 3 children in 3 children who get the BRCA gene. So 3 out of 3 of my mum's blood children had the BRCA gene. The last part of the story is my own testing, and then having gotten married in the last couple of years, having children and thinking about having children. I couldn't imagine having a child and telling them at age 18 of the choices they would need to make. Acknowledging that 20 years on, the science is almost certainly going to be totally different from the science today. But nevertheless, that was my feeling when Natalie, my wife, and I were talking about having children. We then went on to have PGD IVF treatment, which is when the embryo is tested before it's re-implanted into a womb for the BRCA gene. And we now have our first child, Sadie Leia, who, please God, 99.99% is BRCA free. And that's been our experience of having children. I think I'll leave it there. I don't have, like, my interest as a rabbi in Jewish community is that we send out a message collectively that people need to know what BRCA is. What they then do with that is really up to them. Certainly, if we'd known about BRCA after my mum had passed away, or even before my mum passed away, we might have been able to, in some guise or another, protect our family more against cancer. I can't look into a crystal ball and tell you what that might have meant. If my little sister was still around, that would be most wonderful. And it's a good place to stop.
Thank you so much for that. I think I completely agree with you, and I think that's something that really to make clear in this whole session is we're not saying that everyone should go out and get tested. We want to make sure that, as Rabbi Oliver says, that people have access to information and have access to, if they do want to find out this information, that they know where to go, and for all the reasons that Rabbi Oliver's just said then. So thank you so much for sharing that with us. That's so.
If the numbers are even close to correct to what you're describing, that 89% of people in the Ashkenazi, Jewish and Sephardi demographic don't know about what BRCA is, then we have a lot of work to do as Jewish community. And this webinar is obviously aimed at that Jewish community to get the word out and to give people real choices about what they can do about this high instance of the BRCA mutation in our Jewish community.
Absolutely.
Thank you very much.
Thank you. If we could move on to Talia now, I wonder if you could tell us a little bit about your story.
Sure. My story's similar to Rabbi Oliver in many ways. My mum was diagnosed with breast cancer when she was in her 40s, 44, and I was about 12 when she first was diagnosed. She went on to have a lumpectomy, followed then by a single mastectomy, and turned down radiotherapy and chemotherapy at that time. And unfortunately, very quickly, it returned to her brain, and there was a lot of chemo and a lot of radio and a lot of very miserable months. And a year and a half on, she was given the all clear. And then a few weeks later, we began to notice she was changing. And again, the brain tumour had come back. and it wasn't long, only a few weeks before she died. She was 46 and I was 14. And from that point in life, I had this overwhelming fear that breast cancer was coming for me. I don't know where it came from. I didn't know anything about my family history at the time, but I hadn't known much about it being cancer. My parents hadn't shared a lot, but I was very convinced that that was the way I was going to go. And, you know, she'd been in her 40s. Her mum had died in her 50s, but it was very unclear what she died from. And therefore, in my head, it was going down in decades, and something was going to happen to me in my 30s. And I very much lived my teenage life that way and into my 20s. And I remember when my husband and I got together, I was 28, and I remember having a conversation with him about how much I wanted children, but how I didn't want to be a mother who had to leave her children behind like my mother had to. At that time, my mum's first cousin in Israel started contacting me. We'd had very little contact since my mum's death, and she started contacting me about this BRCA thing that she was completely fixated on. And in Israel, genetic testing is huge. It's a much bigger thing. And she had had breast cancer, and she had found that she had the BRCA2 gene mutation. And she became completely obsessed with making sure everyone else in the family got tested. And she, you know, would go for months without speaking to me. And then suddenly I would get this contact, and it would be, have you been tested yet? And I didn't really know what she was talking about. It was on posters in the hospital, but it wasn't talked about. I had no idea really what it was about. And then I was working in Malawi, and I found a lump in my breast, and obviously panicked and went to a doctor in Malawi who announced that it wasn't just one lump, there were 5, and they were definitely cancer. And within one night, my husband and I packed up 2 years of our life and flew back to England to have tests, convinced that I had breast cancer. And it came back all clear, it was all fine. And I said to the consultant, you know, could I be tested for the BRCA gene mutation? And he said to me, no, your mum died far too long ago. There's no one to compare to. We can't be doing with that. So at that point, I completely ignored my mum's cousin because I just thought she was talking nonsense. And it was only, 2009? It was 6 years later, after I had my second child, that my GP turned to me and said, you know, with your mum having cancer so early, would you not like to be genetically tested? And I was like, yes, it's all I've wanted. It's all I've asked for. So I signed up. I went to meet the genetics counsellor. She told myself and my husband all the options that were available. She asked if I wanted the blood test. Yes, please. And within a few weeks, I had the confirmation that I had a BRCA2 genetic mutation. It wasn't a surprise to me. It was a gigantic relief that finally I had some, you know, support that I could do something now that I had so long wanted to do. I was offered options. I was offered an elective double mastectomy. I was offered drugs treatment. I was offered a regular... Oh, have you lost me?
No, we can still see you. You're back.
My brother's phoning me on WhatsApp. Sorry. I was offered all of these things, including regular mammograms and ultrasounds. And really, I got home with my husband that afternoon, and he turned to me and he said, "You know exactly what you're doing." And I said, "Yep, I'm having a double mastectomy. This is my thing. This is me taking control of something that until now I've had no control over." It took 2 years. I had to see a clinical psychologist. Then my dad unfortunately got sick, was diagnosed with lymphoma, and so I put off having the surgery while he was having treatment. And then in 2018, he died quite suddenly. He had a recurrence of the lymphoma in his brain and lasted a very short amount of time. And 2 weeks after that, I got a call from my consultant saying, we've got a space in April for your surgery. And everyone said to me, you can't do it. You're devastated about your dad. Give yourself some time to grieve. And I went, let's get these off and let's get on with life. And I did. April 2018, I had an elective double mastectomy. I woke up after my surgery and I laughed. The nurse told my husband that I was completely high on morphine, but I do remember very much just thinking, like, it's done, it's over, they're not there anymore. What a relief. I fell asleep with boobs, I woke up with boobs, and these aren't going to kill me. I had a really simple journey. Like, I've met women who have had much harder experiences than I have had. They've had a much harder time choosing the right path for them. I work with the Royal Free and I go and speak to women and discuss why I went through the surgery like I'm doing now. And there are some women who really struggle with these decisions. But for me, I was very lucky. It was very black and white. It was, get rid of this and hopefully be alive for my children to grow up. And I have never regretted it for a minute. They don't look the same, they don't feel the same, but my children are growing and I'm still here to watch that. And to me, that was the main thing. But as I said, I had a very simple journey. I know Rabbi Oliver and I know his sister, and I know that there have been much harder journeys for women going through this. So it's not all plain sailing. But I really have never regretted a minute of my decision. And if COVID hadn't happened by now, I would also have had my ovaries and fallopian tubes removed. But unfortunately, that's having to take a bit of a back seat because there are more important things going on in the world right now. But yes, I don't know what else I can add to that.
Thank you so much, Tali. I think that's a really, really such a lovely to hear you say at the end that you don't regret any of that and that you feel like you've taken that control. And I think that kind of sums up, certainly for myself as well, how I felt about my experience. So thank you. Moving on to Rachel. Rachel, do you think you can take us through your story if you unmute and...
Yes. Hello, everybody. I'm Rachel. I have the BRCA2 gene mutation. My story started with my mother, Frances. She got breast cancer when I was young, 20 years old. And she went for a mammogram and it showed up that she had cancer. And she was told that she would have to, have a mastectomy. There was no chemotherapy offered to her because they felt that that was the right thing to do for her, no chemotherapy. She had her surgery done and she was in very good spirits, very positive, and everything else. And she actually went 10 years without it returning. And then obviously after the 10 years, it came back. I was 29 at the time. And it was very hard because at that point they had told us that she had, it had progressed and it wasn't curable. We were very gobsmacked because we didn't expect that for it to be terminal. As I said, she'd gone 10 years. Sorry, it's really hard for me to talk. Yes, and she tried to fight it, but it was very, very strong. They didn't at any time offer genetic testing for any of us or talk to us about anything like that. We just assumed that, she got it, through natural circumstances, if there is any natural circumstances to that. And she passed away. After she passed away, my cousin kept saying to me that you really should think about going for genetic testing. Has anybody spoken to you about it? Maybe mum had, the BRCA gene. I was very in denial about it because obviously I saw what my mum went through and I didn't want to go through that. It was hell. And it was just, I can't even, it's very hard to speak about. And I just didn't want to go for it because I just thought, it's not going to be me. That happened to my mum. you know, I don't want to know anything about it if I have got it, you know. And she kept saying, come on, you know, you should go, it's so important. And I thought, I don't, so I said, okay, I'm going to just go and get referred maybe and speak to somebody. So I did, and the doctor said, well, your mum had it in her late 50s, so that would be a time when most people, you know, it's common for people to get breast cancer then, so I doubt very much you would have a 40 gene. I'm not going to put you forward for testing. So I felt relieved in a way, because I felt like, well, that's great, he doesn't think, this professional private doctor doesn't think that I'd be eligible for it, because my mum got it later on in life. My grandmother died from, we didn't know if she died of breast cancer because we didn't know back then, but she definitely had breast cancer, and it probably spread, and that's what she died of. And they said, well, she was 76, so you know, you couldn't possibly, it'd be very unlikely that you would you know, you'd have this mutation. So I went away kind of feeling a bit relieved, because this professional told me that. But then it was niggling me. Something was, I don't know, I'd seen Angelina Jolie, she'd come out and with her gene for, and then I Googled, it came up, if you're of Ashkenazi Jewish heritage, you know, you really should think, if you have a parent on either side, or it's, you know, that's had breast cancer, then you should get tested. So I went back to my GP and said, look, I didn't tell you that I was Jewish. Does that make it any different? You know, does that make a difference? She said, that makes a huge difference, because, you know, that increases your chances. I'm going to put you forward. So thank God that doctor did put me forward. And when I went to the genetic counsellor at the Royal Marsden, she actually said to me, because I didn't have loads of history that I could go back on. I had older parents, and I was young, you know, so I couldn't go back generations. But from what I was telling her, she also said, look, I'd be quite surprised if you have got a BRCA gene mutation, but I'm going to put you forward because you're Jewish. We'll see, and I'm going to put you forward. So I said, I don't. She said, do you want me to go through everything with you about, you know, what if you did have it, what you would need to do, what you could do? I said, no. I said, let's just wait until you find out. Anyway, fast forward a couple of months, and I got the call, and she said, look, I'm actually quite surprised, but you do have the BRCA2 gene. I was very shocked. I didn't take it well, because I thought in my mind, I'm just eliminating this. I'm going on this thing just to say I haven't got the gene, you know, and I could, in my own mind, feel satisfied, and I wasn't expecting that outcome. I did take it very badly, but with my husband's support and us talking through it all, and obviously going to the sessions and speaking to them about it all, it was a no-brainer. The risk was too high. I actually couldn't deal. I feel like I was a ticking time bomb, is how I would describe how I felt with it. And I didn't want the same fate as my mum. You know, I want to see my grandchildren. My mum should have seen her grandchildren. My mum was 67, you know, not very, very young for her age. She was looking after all of her friends. She was as strong as an ox. And I believe that if she had had what I've had done, she'd be here today. And I know I haven't got a crystal ball, but I know that for certain. Because my mum was never ill and had nothing else wrong with her. If she hadn't have got that breast cancer, it wouldn't have spread and it wouldn't have killed her. And I just knew that I had to do it for my children. I had this feeling I never wanted my kids to turn around and say to me, Mum, could you have done something about this? I can say I did the best I could, you know, and it was hard. It was hard to get my head around, and your femininity, and you feel like, oh my God, I'm going to look horrendous, you know, and all these thoughts run through your mind, and the emotions, obviously, and the fact that my mum couldn't have it done, and you know, didn't have it done, but it was hard. But you know, it's the best thing I've had done. You know, it was hard to hear, but it was the best thing for me to have done, just to be there as long as I can for my kids, do whatever I can. That's how I feel. I was told later on through somebody that I could have had the IVF treatment to change the gene or correct a gene. I was told after I had my children. So obviously I found out about the BRCA gene after my children. You know, listen, my children, I wouldn't change them from the world. So, you know, and when they have to be tested, they will be. And by then, I know that things are moving quickly and they have amazing things. And I'm sure the gene will be corrected. You know, I'm not going to, but I just know I can try and protect my family. And that's so important. The most important thing is to protect and, you know, and try and preserve your life. That you know, and that's it. I just wish my mum could have been around to do it, because she would have done it in a heartbeat. And anybody that's worried or thinking, deliberating, don't deliberate, do it, you know. That's all I can say. Yeah, so that's my story. And then I've also got to have my ovaries removed, the same situation with the COVID. Again, you know, it would be something that I'll do. You know, as I said, anything that I can do to reduce those risks is the most important thing to me, and family is everything. And you know, and it's so important. And so you've got to be a bit brave sometimes, right? If anybody's thinking to themselves, you know, I don't want to hear it, I don't want to, you know what, that's life. And none of us want to hear these things, do we? You know, but if you can do something about it. And that is what the consultant said to me. It took me 3 years to have the operation. And afterwards I was thinking, why did I wait so long? It was more stressful before than afterwards. It was complete relief. Before it was like it was hanging over me. And after I have it done, I don't even think about it now. And that's the truth. Very rarely do I think about it. If I hadn't have had it done, I'd have always been thinking, am I going to get it? If I get it, you know. And it's so important, like the lady was saying to us, that, you know, if you have these BRCA mutations, it's very different to somebody that has who doesn't have a mutation. You know, the cancer can be very strong. It can be very strong, and you know, you have to give yourself the best chances. Yes, so on a positive note. And the other thing as well is I do hear of people that have had, you know, it very, very hard. I'm going to say that I had an amazing surgeon who did a beautiful job on me, and I look aesthetically amazing, is what I would say. So I want to tell people that I've had a very good experience with my surgeon, and I look perfect. So yes. If anybody's worried about that type of thing, then I would say that there's amazing surgeons.
Thank you. I think that's a really positive kind of note at the end there. I think it's a really big worry for a lot of women when they're going through these kind of surgeries as to what it's going to be like afterwards. So I think it's really good to hear that positive side as well. So thank you so much, everybody, for sharing your story. I know it's really hard to talk about this stuff. Sometimes it's a really emotional topic, and it's almost like, you know, that's why we need to talk about it. But it makes such an impact to hear about how you've taken some really hard experiences, and then, you know, I think the word control was there, you know, taking some control, use the knowledge, and being able to take action. I think everybody on the panel has taken action. Just to note for anybody, if anyone has any questions that you want to ask the panel about kind of their experiences, anything to pick up on, or any kind of questions at all on the topic, please do type them in. I'm going to move on to some questions now anyway. So first off, Cheryl, your introduction to BRCA was really, really useful. I think one of the things I really want to pick out from it is, and like you say, is people will always be asking, you know, how do I get tested, or, you know, do I qualify? And it's not as easy as, you know, answering it in a couple of sentences. But are there any red flags that someone should be looking out for in their family tree that might mean that they should look into this?
Yeah, so as your speakers have already said, being Ashkenazi Jewish, and if you yourself have had breast cancer or ovarian cancer, that would be an indicator to possibly having testing. And then it's family history. So if you have several family members affected at usually relatively young ages over several generations, that might be a red flag. And also just to be aware, as I said earlier, it's not just breast cancer. So if you are worried, it is worth at least speaking to your GP or asking for a referral to genetics, because we will look into it. But yeah, the main things are multiple family members over several generations, particularly younger than the usual ages.
Thank you. We've had a question sent in. It's a really, really useful question, which is the risk reduction surgery that women can have. So risk reducing mastectomy and having your ovaries removed. How much does it actually reduce the chances of cancer? Does it take it down to 0, or is there still some cancer risk there?
No, so as the names imply, it's risk reducing surgeries, but they do massively reduce the risk. So a risk reducing mastectomy will reduce the risk back to around 5 to 10%, so down to the general population risk, so almost by 95%. And a risk reducing bilateral salpingo-oophorectomy, which is what it's called when you have your ovaries and your fallopian tubes removed, will reduce the risk to around 2 to 4%. Which again is around population risk. But it is important to be aware that there is still a small residual risk. And that's not to frighten people, but just so that if somebody does have symptoms or is concerned, that just because you've had the surgery, don't ignore them. You know, still be aware of the fact that it's a very small risk, but it still is there.
Thank you. Another question there is, I know you mentioned that men are just as likely to carry a BRCA mutation, just as likely to pass it on, and that sons can inherit the mutation as well as daughters. Could you tell us a little bit about, I know you mentioned that does increase cancer risk for men. Are there any screening options for men at all? We've talked a little bit about kind of options for women, but is there anything that men can do?
So there is prostate screening for men over the age of 40. So for BRCA1 carriers, there's still some debate about that, but I certainly usually either suggest my gentlemen go to there's a BRCA clinic at the Royal Marsden Hospital. So that's a good place to be under, because obviously they're doing a lot of the research into prostate cancer, especially in BRCA carriers, or they should be having at least a PSA testing through their GP from the age of 40, with a lower threshold to refer to a specialist if the PSA is raised. And men, just like women, need to be breast aware. So there is, and just like women, you need to check your breasts. Men are more likely to pick up lumps or bumps or changes, inverted nipples, any dimpling of the skin. There doesn't seem to be any evidence about how often men should do it, but it's still recommended once a month, just like women. And I think it is just lack of knowledge as to why that often. But if you know your breasts, then you are much more likely to notice if there's a difference, there's a change. So it is important that people are aware and do check themselves regularly.
Thank you. Question really for Rachel and Talia. You've spoken quite a bit about the risk reduction surgeries that you've had, but these are kind of really big surgeries, aren't they? You know, you were healthy young women without cancer going into it. Was it a difficult decision? Or were you really focusing on kind of that relief afterwards, Talia?
I didn't find it a big decision. I was worried before I had it. Like, don't get me wrong, I was nervous about the actual surgery. It is a massive surgery, and it is, you do have in the back of your head, you know, these are healthy, this is healthy breast tissue. But actually, I think it was the week before I had my surgery, I had to go for a final ultrasound, and the next day I got a call to say that they had found a shadowy patch on it, and I needed to go for a mammogram. And in that 24 hours, it was just, why have I waited so long? Thankfully, it was all clear. It was just an error. But I didn't want to go through that anymore. I hated MRI scans. They were, you know, they were like putting your head inside a drum of a heavy metal band. Like, I hated them with a passion. And I remember coming out my last one saying to my husband, like, this has to be worse than surgery. Like, surgery cannot be that bad. I was worried about it. I said to friends, you know, if I get depressed, if I say to you, you know, I hate what I've become and I can't look at myself, just remind me that my 2 children will have me as a parent growing up. Just, that's all you need to say. But I never had that issue, like, never, ever. And yeah, I go to the Royal Free and I do show and tells, and I get my boobs out and I let people look at them and have a feel if they really feel the need to. And it doesn't bother me. They are what they are. They're part of my life. And I feel very lucky that I was able to do that. like Rabbi Oliver, my brothers both got tested. So there are 3 of us, and actually we had a 66% BRCA2 mutation rate, not the full 100%. And I am lucky. I get to have my boobs removed and my ovaries removed. My brother who's BRCA2 has a BRCA2 mutation. He doesn't. He gets to check himself, and he gets to have PSA tests once a year, and then can react to that. And you know, I get to do the proactive thing and stick 2 fingers up, I guess.
Absolutely. And Rachel, do you feel kind of going into the ovary removal side of things, do you feel similarly, do you think, to how you did about the breast side?
See, I feel that the breast actually is on the outside of your body, so it's not actually affecting anything inside. Whereas obviously the ovaries, it's obviously hormones making us, you know, going through the menopause earlier than what I normally would. So yeah, that kind of worries me a bit about my hormones being a bit imbalanced, but I know that the doctors are very clever, and you know, they're going to help to balance all that out. So you know, I know I'm in good hands. Yeah, I think that's the only thing. So with the other one, obviously it was on the outside of my body, so it actually wasn't really having any effect at all. But yeah, no, as I said, I was really anxious about having it done, and then afterwards I thought, what was I so anxious about? It seems crazy, really, but you just, all thoughts go through your mind, don't they? But no, I would say to anybody, don't worry about it. I mean, it isn't brain surgery from that point of view, you know. It's not something that's inside that's working, it's all from the outside. So if anybody was worried about long surgeries, or, you know, God forbid, it's not going to happen, because it's all on the outside. And as I said, the results for me were amazing. But they always say to patients as well, if they're not quite how you want, we're going to try and we'll do some other surgeries. And they're little surgeries, they're not major, you know, as in, you know, maybe cesarean, for instance, was more major surgery, I would say, than I had 2 cesarean sections. I would say they were more major surgery than what having my bilateral reconstructive surgery was. And also it's the skilled surgeons as well. They're so, I mean, it's almost like all I've got to do, all I had to do was lie there and close my eyes, kind of thing. It's them who are doing all the magic, the skilled work, and it's hard for them because they're having to create it all and do it. And they obviously did a fantastic job on me. So I didn't actually have to really do anything, really. It was all their work. So yes, yeah.
Can I just add one thing about ovaries? I have found the thought of having my ovaries out a lot harder to deal with than the mastectomy.
Me too.
I think partly it's because my mum didn't have ovarian cancer, so it's never been in my head, it's never been a big threat to me. But my mum's first cousin, who's done all the research, she's actually found out that of her grandparents, 4 of the 5 had ovarian or prostate. She's had breast. Other people in her line of the family have had breast and ovarian. So it is still very much a risk. But I was not looking forward to it. It more because of children and that end of that choice to have children. I didn't find out I had BRCA2 mutation until after I'd had children, so IVF wasn't an option. But yeah, your ovaries are a bit more functional than your breasts are. I mean, you can't escape that. So I still have an issue with the fact that I'm having it done. I do still desperately want it done, but I think I'll find it hard to say goodbye to them, even though I've never met them before.
Can I also add one small thing? I guess from my perspective, I think the same thing happened last year when Talia and I were on a panel, but there were complications with my twin sister's surgeries, and she ended up having a year of corrective surgery. So that was a much tougher process than either Talia or Rachel describe, and some of those complications can have long-term consequences. And the same with the oophorectomy, having your ovaries and fallopian tubes removed. The problem in my family is that my mum passed away at 57 and my little sister before the age of 30. So there'll be some people listening to this who will find out at a very, very young age that they're BRCA carriers, and might also have family members who passed away at a very, very young age, and deciding to have a oophorectomy before the age of 30 or even before the age of 40 is a huge decision because of the hormonal effects of being forced to go into early menopause at a very young age. So not to in any way detract from Talia or Rachel's experiences, but there are kind of big choices that should be made, and the doctors, I think, not that I've been there, are good at describing the risks, but often the risks are things that we psychologically glaze over because we hope that it's not us. It's called wishful thinking. So there's a lot there to kind of balance up when people go in to be tested and then consider their options in relation to surgery. It wouldn't be my place just to say it's all fine, because that was the experience of our family, that those choices and experience don't always go tickety-tock, if that makes sense.
Can I just jump in there, if that's okay? Just to say, you're absolutely right. Some people breeze through surgeries, and some people have really complicated and have to have surgeries repeated, and as you say, infections and all sorts of things. But just to say, in terms of having the ovaries and fallopian tubes removed, they usually wouldn't do that until somebody's completed their families, and for BRCA1, late 30s to early 40s, and BRCA2 from their 40s. It's still very young, and they would usually recommend hormone replacement therapy as long as they hadn't had breast cancer, and that's because it's not just the things that go, hot flushes and concerns about going into menopause, but there are also medical issues like if you increase risk of bone disease and heart disease. So all of that is taken into account, but we certainly wouldn't be wanting to take out ovaries in very young women for those reasons. There is also some research studies going on at present, which are very exciting, looking at potentially two-stage surgery. So removing the fallopian tubes where most ovarian cancers begin, but keeping the ovaries up until more or less the natural age of menopause. So you retain some risk, but you retain the function, and you don't get as many of the side effects. But that is really, really much in the research phase at the moment. But they are looking at different options for this reason. And also, just to say, a lot of women, some people find the risk-reducing mastectomy far more challenging in terms of their appearance, and as I think Talia, you mentioned, you had to see a psychologist. That's as it should be. Whereas with having your ovaries out, they don't always recommend that, but there usually is a psychologist that you can see if you're having concerns and worries about issues around going into early menopause, because that is a really real issue, and it is a real concern for many women.
Thank you so much for that. I think that's really, really useful to hear that, all the guideline side, and also I think it's certainly the case that, we need to take into account all the risks and possible things that can happen. I had the same thing when I had my double mastectomy. My one surgery turned into 4 over 18 months, and that does happen, like you say. And I always say to people, whatever kind of risks that are explained to you when you're about to have a surgery, it's very easy, particularly when you're a healthy person going into it like this, to think, oh, that won't be me. And I always now say to people, have a backup in the back of your mind as to, if this happens, do I have someone who can pick the kids up? Do I have enough time off work? Or just at least consider, what will I do if these things happen at the very least? And then, positive thinking, it won't happen, but if it does, you're kind of prepared. But I'm aware that we've kind of chatted through quite a lot at the moment, but there was a kind of burning question that I wanted to ask everybody. I'll start with you, Rabbi Oliver, but considering the fact that, as we've said, members of the Jewish community are 10 times as likely to carry a faulty BRCA gene as the general population, and adding in the fact that we know from lots of research that only using family history to catch this doesn't work, because up to 50% of people who carry a BRCA mutation don't have any family history. The burning debate question is, do you think that all Jewish families should be offered testing for faulty BRCA genes?
Yeah, should be offered. I mean, I think it's really important that this conversation comes up. There are lots of things that Jewish community need to talk about. Cancer is not the only thing that we need to be talking about around the Friday night dinner table. But it's one thing that, by no choice of our own, in this, I think I wrote last week, we're the chosen people in this, in carrying this BRCA gene in higher numbers than the general population. I think we need to face up to this, and that I'm actually surprised today that the people who don't know are in the 90th percentile. That the level of not knowing about BRCA is so high in our Jewish community, and I think all of us need to carry on doing this work so that people know that they have the option. The other aspect of it, which I'll just throw in, which is like a side piece, is that I don't want to in any way go against the choices that Talia and Rachel have made, but one of the parts is that there is, if you know, then there are treatments available by way of having IVF that you can eliminate this gene before you have children. And that doesn't help people who have already had children, but it has been there for us. The BRCA testing in the NHS, I think, is tip-top and starting to get to the level that it needs to be. The IVF provision is pretty terrible. And so the number of appointments that we would have needed to have a child on the NHS would have taken us, we calculated, about 3.5, 4 years, particular to our medical condition, to our medical circumstance. So there's kind of a little bit of an imbalance in terms of the BRCA testing seems to be there. Some of the options in terms of IVF might not be there. And so also as a Jewish community, we need to think about how we also advocate for some of our NHS departments in some guise or another. So that's a bit of a tangent, but also thought that's appropriate to mention.
Definitely, thank you. I don't know what you think, Cheryl, in terms of that topic. Do you see a future where maybe all of the Jewish population will be able to come and ask for a test if they want one?
I think 5 years ago they could. Up until about a year ago, we fought very hard to, at least within the northern, in North London, to keep it more open. Unfortunately, they are moving away from that a little bit, and population testing as such is not going to be available. So there are a lot of people arguing against that. So there's some papers, as you know, you're quoting them. I know with the papers you're quoting, show evidence that it would be of value, but I'm not sure the NHS are going to actually be able to provide that service, to be fair. Do I think they should? Yes. Will they? No. I am sorry that you struggled with the PGD service, because actually it is quite excellent. So people are more able to access that for BRCA now, but it is lengthy, and there are a lot of restrictions on that service, but because of financial constraints would probably be one of the reasons. But yeah, it would be lovely, but I don't think it's going to happen.
Thank you. We've got a couple of questions just come in just towards the end, Cheryl, that I don't know if you can cover reasonably quickly, but is testing for BRCA done by a simple blood test, and also at what age can somebody be tested? So for example, if somebody in their teens had a medical condition that might indicate that it was necessary, are they able to be tested, and what age can you test your children otherwise?
So to answer the first question, it is usually a simple blood test. Obviously, for people who are needle phobic, there is the option of saliva tests, but blood tests are the usual way that we do the testing. In terms of the age that we offer testing in children, it is generally the age of 18 that we offer testing. I did see the question. So if somebody was presenting with something that if they did present with a cancer at that age, and it was a cancer that's linked to BRCA, then I imagine they would test. I've not heard of any cases. So often ovarian tumors that are at very young ages in teens are not actually BRCA related. So some ovarian cancers are not linked to BRCA. So I appreciate that can be difficult, but if you are worried, ask the question, get the referral, so somebody can look into it for you. So we very often, especially with ovarian cancers, request histology. So it frustrates many people that they assume we don't believe them. But the reason is it's really important we know what the histology, so the particular type of tumor that might, because some tumors are not cancerous, and also not all cancers are, even ovarian cancers, are linked to BRCA. So I hope that answers it.
Yes, thank you. Just to wrap it up then, I'm going to ask a couple of you, just put you on the spot. Talia, if you could kind of give one message to people in the Jewish community about BRCA, what would it be?
It would be talk. Knowledge is power. No one talks about cancer. When my mum was ill, I don't think she knew anyone who'd had breast cancer. Her friends were fantastic. They were all around her. The community were amazing, but she was very lonely. And although I don't remember a huge amount, really, I know how sad she was. And nowadays we talk and we have social media, and people are far more vocal about things. And women particularly are far more vocal than they were back in the 70s, 80s, 90s about certain things, about health. And I just think talking, sharing knowledge is power. So that's what I would advocate.
That's brilliant. And just to the final note I wanted to say, Cheryl, I know you've already covered this, but I wonder if you could just repeat again. If anybody watching this feels like this is something they want to look into, what should they do?
So if they're worried about their personal family history, ask your GP or your doctor, if you're having treatment, to refer you to your local genetic service, and they will then assess whether genetic testing or an appointment is appropriate, or whether any advice is needed for you based on your family history.
That's brilliant. Thank you so much. We have overrun a little bit from the time that we said we'd take. So I just want to say thank you to everyone for coming along and watching. I hope this has been really useful. I do want to send everyone away with one piece of homework, which is to have some conversations, as we've just said, talk, find out a little bit about your family history of cancer, and start to kind of find out if you do have any of those red flags that we've discussed. If you're concerned by what you find, if you want to ask any questions, you can start off by looking at our website, ovarian.org.uk. I'll send that information through to you in the email after this as well. We do have a really simple hereditary cancer risk tool that you can use if you do want to kind of have a bit of a check before you go to your GP, that just asks a few questions about your family history and gives you a kind of a brief idea as to whether you might be wanting to go and speak to your GP about it. So again, thank you all so much for coming. I want to say a huge thank you to all of our panel members. I know some of this is really tricky to talk about, and you've given up your time so willingly today, and really, really grateful. It makes such a difference. So everybody, please let me know if you have any follow-up questions at all. Get in touch at any point, and we will help you out. But thank you so much again, and I hope everybody has a really lovely week. Thank you.
Bye.
Bye.
Thank you. Bye. Thank you. Thank you. Bye.